Today's topic. In the previous video, we discussed about the approach of AKI, and in this video, we'll discuss more about pre-renal AKI. Shock or hypovolemia, which will be it's a larger topic and we'll do it in a separate video. Renal artery stenosis and drugs that cause AKI will be discussed in this video, and hepatorenal syndrome will be discussed in the next video. Coming to renal artery stenosis is the obstruction in the renal artery. It can be either unilateral or bilateral, or it can be either gradually progressive or it can be acute. Coming to the causes of renal artery stenosis, there are three main causes. The first cause is there is gradual accumulation of fatty substance in the lumen of the renal artery. That is atherosclerosis, and this is the most common cause for renal artery stenosis. This mainly occurs in old aged people, and this is mainly associated with other comorbidities like diabetes mellitus, primary hypertension, and thyroid problems. And people with this is at increased risk of getting MI or stroke. And coming to the second cause, this is the renal artery, and there's accumulation of fibrous tissue in the muscular layer of the artery. That is, because of increased fibrous accumulation, it gets narrowed. So, obstruction in the renal artery. That is, fibrous tissue is replacing muscular tissue or increased fibrous tissue in the muscle. So, therefore, we call it fibromuscular dysplasia. This occurs in almost about 10% of the patients with renal artery stenosis, mainly occurs in young people, and it's more predominant in females, and it is known to be genetically predisposing. And mainly occurs in the iliac, renal, and the carotid arteries. Coming to the next cause, that is a blood clot obstructing the artery. This can be either a thrombus, that is, it has formed here, or it can be an embolus, that is, formed elsewhere or has come here. Atherosclerosis and fibromuscular dysplasia progress gradually, whereas thrombus or embolus occurs acute or subacutely. Coming to the clinical features, the main clinical feature is due to decreased blood supply to the kidneys. It stimulates renin production. This renin in turn stimulates the angiotensin and it further stimulates the aldosterone. Angiotensin causes vasoconstriction of the arteries, whereas aldosterone causes sodium reabsorption. Because of vasoconstriction, the peripheral resistance, that is the resistance of the blood flow, increases. Because of sodium reabsorption, water also gets reabsorbed, which results in hypervolemia, increased volume, which results in increased cardiac output. Increased peripheral resistance causes increased diastolic blood pressure, and increased cardiac output causes increased systolic blood pressure. Put together, we call it hypertension. And because this is due to a known cause, that is, it's secondary to renal artery stenosis, therefore we call it secondary hypertension. And as I said earlier, it is a pre-renal AKI. Therefore, because of AKI, the renal functions will be elevated. The renal function test will be elevated. That is, serum urea and serum creatinine, blood urea and serum creatinine will be elevated. Serum creatinine will be elevated much more than creatinine, as explained in the previous video. And coming to the investigation part, the main investigation for renal artery stenosis is duplex or Doppler ultrasonography. The advantage of this is it detects the velocity of the blood in artery. Because of stenosis, because of obstruction, the velocity increases. Therefore, if the velocity is more than 200 cm per second, then it is a significant stenotic lesion. And CT or MR angiogram can be done. Because these use contrast, and patient is already prone for AKI, and contrast can injure the kidney. Therefore, this should not be done when the GFR is decreased. That is, it can be done only in people with normal GFR. In angiography, in fibromuscular dysplasia, there is hyperplasia followed by a normal area, and hyperplasia and followed by normal area. It alternates between them, not regularly but irregularly. So, if we give the dye and we take the film, we take the scan, the dye takes up the lumen and it appears like this. This appears like a string of bead. So, string of bead appearance in angiography is seen in fibromuscular dysplasia. And the other investigations are thyroid profile. Normally, thyroid increases fat metabolism. In hypothyroid, there will be decreased fat metabolism, that is, fat will not be broken. Because of this, there will be increased fat accumulation, that is hypercholesterolemia, which predisposes to atherosclerosis. And we should do lipid profile to check for hypercholesterolemia, the total cholesterol, triglycerides, and the low density lipoproteins. And then we need to do ultrasonography to visualize the kidneys. In case of unilateral renal artery stenosis, one kidney will be shrunken than the other. Therefore, in case of unequal kidneys in ultrasound, suspect renal artery stenosis first. Coming to the treatment part, it has a medical treatment and a surgical treatment. In medical treatment, the first thing is to control the blood pressure. Because it is a renin angiotensin aldosterone pathway, we can give angiotensin converting enzyme inhibitors and angiotensin receptor blockers. This should only be given, that is, angiotensin converting enzyme and angiotensin receptor blockers can only be given in unilateral renal artery stenosis, not in bilateral renal artery stenosis, which I will say in the later part of the video. So in bilateral, we give beta blockers, calcium channel blockers, and diuretics to control the blood pressure. This is one part of the treatment. And the second medical treatment is because of hypercholesterolemia. This can occur. So to decrease the cholesterol level, we give statins, atorvastatin, rosuvastatin, simvastatin. And because there is a risk of heart attack and stroke, we can give antiplatelets like aspirin and clopidogrel. And coming to the surgical treatment is reperfusion, that is using stents, balloon catheters. Now, indications of medical treatment and indications of surgical treatment. First, the indications of medical treatment. That is, the GFR is controlled and there is a controlled BP. And in regular follow-up of the duplex scan, the renal artery stenosis is stable. These are the indications for medical treatment. And for reperfusion, severe decrease in the GFR even when the patient is on treatment, and BP is not controlled even when the patient is taking the antihypertensive drugs, and there is severe renal artery stenosis, that is more than 60% stenosis, are indications for reperfusion. And in case of thromboembolic renal artery stenosis, the treatment is, apart from the previous set, the treatment is anticoagulants and thrombolytics. And here is how drugs causes AKI. In a normal kidney, there will be a normal GFR. Whereas in a chronic kidney disease kidneys, there will be a decreased GFR. Therefore, to stabilize the GFR, there are three intrinsic mechanisms in the kidney, normal intrinsic mechanisms in the kidney. Those are: decreased GFR activates renin. Renin activates angiotensin. Angiotensin activates aldosterone. Angiotensin causes vasoconstriction of the efferent arteriole. This increases GFR. How this increases GFR will be discussed later in the video. And then decreased GFR stimulates the production of vasodilatory prostaglandins, which causes vasodilation of the afferent arteriole. And decreased solutes in the tubules. Because of decreased GFR, there will be decreased solutes in the tubules, which in the macula densa. Macula densa is a part in the distal convoluted tubule. This senses the solute concentration. This, when gets activated, stimulates the prostaglandins and the renin, which causes vasoconstriction of afferent arteriole, vasodilation of afferent arteriole, which increases GFR. And this is how they increase GFR. This is the afferent arteriole. This is the glomerular tuft and the efferent arteriole. And this is the glomerulus. Fluids and electrolytes from the tuft enter the tubules. This is glomerular ultrafiltration. When the pressure is more ultrafiltration takes place. More pressure, more filtration takes place. This is afferent arteriole. When afferent arteriole dilates, more blood enters, therefore pressure increases. Therefore, more the pressure, more the filtration. Therefore, more solutes and fluid enters through the ultrafiltrate. More the GFR. And when efferent artery constricts, the pressure increases because blood cannot easily cross it. Therefore, increased ultrafiltration. This is how vasoconstriction of efferent artery and vasodilation of afferent artery increases GFR. And now, coming to the drugs, the non-steroidal anti-inflammatory drugs, which are most commonly used for like any febrile illness or general body ache, ibuprofen, aceclofenac, and for pain, these are analgesics. These block the prostaglandins. And AC inhibitors and ARB. The AC inhibitors, the enalapril, captopril, most commonly used antihypertensives, and angiotensin receptor blockers, the sartans. These block angiotensin, that is angiotensin converting enzyme blocks the formation of angiotensin 2, and angiotensin receptor blocker also blocks the formation of angiotensin 2. Therefore, AC inhibitors and ARBs block this pathway, and the NSAIDs block this pathway. Therefore, in a chronic kidney patient who have a decreased GFR, only these pathways stabilize the GFR. So if we give drugs which inhibit this pathway, it results in AKI. So while using these drugs in CKD patients, we should be careful. This is the reason why we do not give AC inhibitors in bilateral renal stenosis, because it will have a very much severe decreased GFR, and AC inhibitors will further prevent the increase of GFR by intrinsic pathway. Thank you.